Welcome, everybody. Thank you very much for joining us for our webinar this evening on sex in the menopause, why your best sex is yet to come. And a big welcome from Dr. Clare Spencer. So Claire, if you want to wave, who I'm sure all of you know, co-founder of my Menopause Centre, along with myself. And Claire and I, Dr. Clare and I, believe that the best way to smash a taboo is to talk about it. And while we talk about the taboo around menopause, there are taboos within taboos, and sex is probably one of the biggest one. Various studies have shown that anywhere from 40 to 50% of women going through the menopause experience loss of sex drive, and around 1 in 3 vaginal dryness. And I know from speaking to Dr. Clare and the other doctors in the clinic that you all think that's probably massively underestimated as well, because so many women are still too embarrassed to speak about these symptoms, even with their doctors. So we really do need to smash this taboo. So in addition to the brilliant Dr. Spencer herself, we're joined by 2 amazing women. And they will help us really round out for a very holistic discussion about sex and menopause. So we've got the fabulous Sue Lennon. Sue is a highly experienced psychosexual therapist. She originally trained as a nurse, and on qualifying, she specialized in oncology. Sue worked as a Macmillan nurse specialist for 14 years, and she recognized very quickly the impact of cancer and cancer treatment on the sexual impact of them, and that these were rarely discussed. So Sue set out to put this right. She qualified as a psychosexual therapist and went on to develop a sex therapy service alongside her clinical practice, with the aim of helping those suffering the sexual consequences of changing life illnesses and spinal cord injury. And in recent years, her practice has expanded to the world of perimenopause and menopause, and she's as passionate about supporting women through the menopause as she is in the other areas. And then on to Eleanor Gardner. Eleanor is a very familiar face to the My Menopause Centre community, having joined us previously on a couple of other events. Eleanor founded the fabulous website Pelvic Relief in 2013, bringing together a range of products for pelvic health to manage conditions such as painful sex, incontinence, and pelvic pain. Eleanor also works as an ambassador for the Yes company, I probably threw in a yes too many there, Eleanor, but manufacturers of organic lubricants and vaginal moisturizers. Eleanor, again, eminently qualified and an expert in her area. She's a master's degree in physiotherapy and has worked with medical devices since 2007. I mentioned at the top that we're all slightly jealous of Sue. Sue is joining us from France, where she resides, but she does do counselling via video as well, Fred. She's clients from all over the world. So it's an honor to have you all here this evening, guys, and thank you so much. So there are 2 parts to the conversation this evening. In the first part, we'll cover off the gynaecological symptoms. So the symptoms that can cause pain and discomfort during sex, because it's hard to even contemplate having a sex drive when it's painful in the first place. And then we look at the treatment options for that, and of course, loss of sex drive. So without further ado, I'll hand over to Claire for our first question. Claire, I mentioned at the top the British Menopause Research Society that you looked at when you were writing all that fabulous content on the website. Is this consistent with what you see in the patients that you see in your practice?
Yeah, thanks, Helen, and good evening, everybody. I think it's a massive underestimation, actually. I think a lot of women don't volunteer the information, and often it's not until you ask that people will actually tell you that they have a degree of dryness, a degree of discomfort when they're having sex. And so, patients, I call patients in my clinic, will say that there's just like a general scratchiness, irritation, itching, no discharge, or lots and lots of vaginal discharge. But the main thing is the sort of painful intercourse, pain on penetration, even if, for example, using a sex toy. Because of the elasticity loss, that loss of stretch at the entrance to the vagina, that can be such an issue as well. So massive range of symptoms and very much underreported. And I know, Helen, we've talked, haven't we, about sort of really trying to reiterate the terminology. So a lot of people use the term vagina when actually they might mean the vulva on the outside rather than the vagina on the inside. So I just thought it might be useful to put up a slide that shows. I don't know if you saw fairly recently, a few months ago, there was a study that was published through the Guardian that showed people just aren't 100% confident about their anatomy. So here we go.
Can everybody see that?
Yeah, so this is from our website. And so this is just showing that this is the vulva, or the perineum is part of this, but this is the outside bit. And the vagina, you can see the vaginal opening down at the bottom, which is the vagina inside bit. And actually in the menopause and for painful sex, both areas are really relevant. So if we work from the top down, you can see the clitoris. The clitoral hood is the sort of fold of tissue that covers that. The urethral opening is the opening from the tube, the urethra that drains the bladder. The labia minora are the inner lips of the labia majora are the hairy ones on the outside. The vestibule is sort of thought of as the area in between, and then the vaginal opening, which obviously opens up into the vagina that then leads up into the cervix, which is where you would have a smear. So there you are, quick anatomy lesson. But I think it really helps, because then when you're talking to me or talking to your doctor, we can quite quickly pin down where the issue lies.
Great, thank you, Claire. And I should say, as we go through the chat this evening, I think if you have any questions, if you pop them into the chat, and then I'll stick them in the Q&A, and we'll address them as we go through the course of the evening, or we'll answer them at the end of the evening too. So Claire, that was really, really helpful. So what are the different ways that symptoms such as vaginal dryness and painful sex, what are the different ways that they can be treated?
Yeah, well, I think then before we think about how to treat it, we just need to take a step back and think what's causing it. So in the menopause, the levels of estrogen fluctuate and drop. And actually, even in that early menopause transition, where the estrogen levels are bouncing around a bit and fluctuating, on average, they'll be lower. And then in the menopause and the post-menopause life, the estrogen level is low and stays low. And the relevance of that is there are estrogen receptors in the vagina, in the urethra, that, remember, the tube that drains the bladder, in the outside vulval tissues. And so one of the best ways of treating symptoms is to actually give some estrogen back. So for some women, if you've got other menopause symptoms as well, systemic HRT, and by that I mean the HRT that you either swallow or put through your skin, can be helpful. But also topical vaginal estrogens. So about a third of women, depending on which study you read, on systemic HRT will also need a vaginal estrogen. And some women, actually, their main symptoms are vaginal, in which case they'd only really need a vaginal estrogen. And so you can use vaginal estrogen creams. There's a gel. There are tiny little pessaries. There are sort of bigger bullet-like pessaries. And there's a ring that can be inserted and stay there for 3 months, releasing estrogen into the vagina the whole time, which can be really helpful. So from my medical point of view, I would say vaginal estrogens, but also I know that Eleanor is going to talk in a little while about the alternative. So it's not the only option, but for the majority of women, a vaginal estrogen will be safe, with none of the risks of, although small risks of systemic HRT. And it's completely fine to have both. Sue, did you want to come in?
I just wanted to ask you a question, actually.
Yes.
If you use vaginal estrogen cream, I'm asking because I went for my smear recently, and it's a midwife that looks after your smears in France. And she said, oh, you're a little bit atrophic. Maybe you would benefit from some cream. And I said to her, can I still use my normal lube with this cream? And she touched me on the leg and she said, honey, I don't think you'll need to. and she was absolutely right. My natural lubrication has returned. It's fantastic. So that was one thing. And then another little anecdote, because she gave me my prescription and off I went to the pharmacy. And it's interesting, isn't it, the cultural difference around talking about sex. So of course I went into the pharmacy, little tiny village pharmacy, and gave them my prescription. And the man scuttled off into the back. He was there ages. And he came back. He obviously couldn't find what he was looking for. And he literally, in the middle of the shop, said, "Is this cream for your vagina?" I thought, never in England.
Not in England. You'd be taken off into a little room behind the counter.
But my other question was, Claire, very quickly, if you're using estrogen cream vaginally, does that have any impact on your partner if they give you oral sex?
Oh, really good question. And with the preparations that we use at the moment, it's really unlikely to cause feminization basically of your partner, so it's fine because they're all quite low doses. In the olden days, there used to be a really potent estrogen cream that's not on the market anymore, and I think there was some anxiety with that. But so if oral sex is an important part of sex for you, then the little tiny Vagifem pessaries, I'll find one, I'll show it after, can be helpful, but the cream is fine.
Yeah, brilliant.
Yes, yeah. You probably wouldn't want to swallow a whole tube full, but it shouldn't cause any issues for your male partner or female partner. Yeah.
It was just an interesting kind of, nobody ever asks or nobody ever tells you that,
Yes, and it is fine to use lubes as well as vaginal estrogens. It shouldn't be an issue. Probably wouldn't want to use them all at the same time, particularly with the cream or the gel. But if you use a lube or a moisturizer, or moisturizer in the day, you use the vaginal estrogen at night, it is completely fine.
Yeah, that's what she said.
Mm.
Thank you.
Claire, a couple of questions coming in. One is around from somebody who'd like to know where they can get estrogen cream from.
Yes, on prescription. So I don't know if you'll have seen in the news in the last week or two, there's been publicity about over-the-counter HRT, and that actually was relating to vaginal estrogens, but in the UK at the moment, only on prescription from your doctor or healthcare professionals. Some nurses can prescribe.
Yeah, I guess keys you can get it on the NHS. And then another question here from a lady whose doctor has prescribed Vagifem pessaries twice a week, but she's wondering if she can use it more often because she's still having issues.
Yeah, so the licensed dose for Vagifem is 10 micrograms. It's a tiny pessary, one every night for 2 weeks, and then one twice weekly. But it is a low dose, and particularly if you've had symptoms for a while, or you've got a really severe vaginal atrophy, really super delicate tissue, off license, you can use them a bit more often. You probably want to discuss it with somebody, but there used to be a 25 microgram pessary available, and it was only withdrawn for commercial reasons. There were no safety worries about it. So I do sometimes tell women to, if it is bad, to use 5 times a week, for example. Yeah.
And then we'll come back. So for people who've put questions in the room around testosterone, we'll come back to that in just a moment. And Claire, I think you might have touched on it earlier, but okay to use vaginal estrogens in addition to HRT for people as well.
Yeah, absolutely. If you read the leaflet in the vaginal estrogen, it's terrifying. It has all the risks of swallowing estrogen, so risk of blood clots, etc. But that's hopefully going to change. There is no risk of blood clots, no risk of breast cancer from using a vaginal estrogen, and it's fine to use it with your normal HRT.
Brilliant. And then Eleanor, Claire touched on the fact that, you've got loads of knowledge and experience around other alternatives to HRT. So a good question that's just popped in, maybe to kick you off, is what are the best lubricants and what are the difference between them?
Well, that is a really good question. So I think to start with, when we're looking at the non-hormonal options, it's worth considering what a vaginal moisturizer is versus a lubricant. So a vaginal moisturizer is a non-hormonal moisturizer that is used to deliver water to the tissues. So it's rehydrating the tissues. So whereas the vaginal estrogen products, the creams, the pessaries that Dr. Clare was talking about, are re-estrogenizing the system, vaginal moisturizers are there just to re-deliver water to the tissues, and they can be used on a daily basis, and they can be used alongside something like Vagifem. A lubricant is designed to deliver more lubrication over a shorter period of time, primarily to make sex more comfortable. So moisturizer, think of as your daily moisturizer, like you would use a face moisturizer. You can use it as much as you want to make yourself comfortable, and a lubricant would be additional lubrication for sex. And I know in the introduction you sort of touched that I've been working on with devices for quite a while, but I was really lucky early on in my journey in pelvic health to come across the Yes Yes company, and I now work as an ambassador for them. But Sarah and Susie, who founded that company, really examined how moisturizers and lubricants were made, and for a long time they'd been made really cheaply just to be slippy, but nobody had really thought about gynaecological health when these products were being manufactured. So the Yes products are just a superb range of products that are really consider gynaecological health. So they consider the natural pH of the vagina. They avoid ingredients that are going to cause irritation. They avoid ingredients that we really don't want on the mucosal lining of the vulva and in the vagina, which a lot of moisturizers and lubricants do contain. So my primary advice is, when you're considering your lubricant and your moisturizer, is just to know that not all products are equal, and really understanding your ingredients list and talking it through with your doctor. And if you're finding a moisturizer isn't right for you, it might be that you're just using a moisturizer that's actually causing a bit of irritation, or is ending up causing thrush because the pH of your vagina is off. So I have got, it's sometimes easier to see, but oh, I don't know if you can see that. The vaginal moisturizer is the lighter tube, and then Yes do 2 lubricants. They do a water-based lubricant, which is a very natural feeling lubricant. It's pH matched to the vagina. It's got that water content. It will have a hydrating effect because it's got that water in it. And then they also do a lovely product, which is an oil-based lubricant. Now, this doesn't have a water content, but it's a really nourishing, rich cream that's very long lasting. So if you've got any microabrasions on the vulva, if you're really sore, it's very protective. It is worth noting that any oil-based lubricant you can't use with a condom though, so that is worth considering. But they're also lovely to use in combination. So an oil-based lubricant on yourself to protect the tissue, to nourish the tissue, and then a water-based lubricant on your partner or on your dilator is a really lovely combination, because the two will sort of slide over each other.
Brilliant, Eleanor. That's really helpful, and you've answered an awful lot of questions just in that alone. And then one of the things that we discussed was around the importance of the health of the pelvic floor. So it would be great, you know, given your experience, if you could help us all to understand why the pelvic floor is important and how it affects our enjoyment or otherwise of sex.
Yeah, absolutely. So the pelvic floor is this basket of muscle that sit in the base of the pelvis. And it's really, these muscles, I think of them like an orchestra. They have to contract and relax at different points, and they're involved in bladder and bowel function and also sexual function. So this basket of muscle that sits in the base of the pelvis, and then as females, we have entry points. We have the urethra and the rectum, and we have the vagina that comes through the pelvic floor. And these muscles are there to keep us continent. They're involved in their contraction of these muscles around the vaginal canal are involved in orgasms. And when there is a painful stimulus, so if you've got some atrophy of the vagina because of this lack of estrogen that Dr. Clare was explaining, this can cause pain on penetration, pain with touch. What our muscles tend to do all over our body is, when there's a painful stimulus, they will contract, which is a protective function. So if you've ever hurt your shoulder, you'll find that your neck's stiff, all your back muscles become stiff. And this is because the muscles are contracting to sort of protect that joint. Now, if sex has become painful as a result of menopausal atrophy, often what happens is the pelvic floor can go into a real spasm, which can then end you up in a cycle of further pain. So your body recognizes that penetration has become painful, and then you get this contraction of muscles, and this global contraction can be, there are a few different diagnoses, but you can have something called vaginismus, which is this sort of global contraction, dyspareunia, which is referring to particular pain on penetration. So part of the job of treating your gynecological health, there will be, of course, this re-estrogenizing, this lubrication, getting that working again. But also there might be a really important part to play in being able to relax these muscles again, to learn that these stimulus aren't painful again. And that can involve working with your doctor or psychosexual therapist, or perhaps even a pelvic health or a women's health physiotherapist, to help you learn how to down train that tension. There are also some super devices that you can use actually at this stage. I don't know, Helen, is now a good time to mention a couple of those? So I've brought a couple with me just to show you, but your doctor may, or your physiotherapist may well talk to you about something called a dilator. And I've got a couple of different sizes here, but these are just silicone. They're very flexible, they're really soft, and they are going to be to help, one, give a little bit of a stretch if there has been a physical atrophy of tissue. And the other thing they will do is help you down train those muscles. So help you, your body, understand that this isn't a painful stimulus. So to achieve that, you'd start with a really small dilator, which is about the size of my little finger. So this is really is the smallest you can go. And you'd use loads of lubricant, get yourself in a position where you're really relaxed. You're not going to be disturbed either in the bath or in your bedroom, where you can be calm. And what you want to do, loads of lubricant, and just start with the tip of the smallest dilator, and you insert that, and you do your breathing exercises. And you as soon as, you never want to work through pain. So if that's not painful, you can then slowly grade up through the sizes until you can reach a point which you would feel comfortable with, depending on what you want to achieve, whether it's a smear test or whether it's sex with your partner. So dilators are really useful tools for that. We've also got a super device I've brought here, which is called the O-Nut. Now, the O-Nut is a set of 4 silicon rings that stack together. They're really stretchy, and they sit on the base of the penetrating partner, or they can sit on the base of your dilator. And what they're going to do is create this really soft buffer to prevent sex from reaching a painful point. So if you've found that deep penetration is painful, so you're getting deep dyspareunia, you can put this on your partner or on your dilator, and it will just create that really gentle buffer, which means sex won't get to a point that is painful, which means you'll be able to avoid that sort of over contraction of the muscles. So by bringing these into this sort of conversation, I just really wanted to give you a sense that there are some really great tools out there that we can use. So it's really important to have a conversation with your doctor about the sort of thing that is out there that might be able to help you, depending on what exactly is going on for you as an individual.
And Eleanor, a couple of comments, or 2 to 3 comments coming in here that just, resounding endorsement of what you said about the yes products. And Deborah, thanks for the feedback that you've used yes lubricant after watching one of our talks, and it's really helped. So that really is great to hear, because we obviously get so many questions about recommendations. Before coming on to Sue, to pick up on one of the points you made around psychologically, how do you relax if it's painful? Just a very practical question for Dr. Clare and Eleanor. And Eleanor, you mentioned that, sometimes you might want to use dilators, not just for sex, but to help you with your smear test. Now, obviously, continuing to have a regular scheduled smear test in your 50s, 60s and beyond is really important. But clearly, if it's painful to go through, you're maybe less likely to do it. What are the practical tips that you could give to people, give to women, so that they can make their smear tests? Let's face it, they're never going to be the thing you most look forward to, but they are really important. What can women do?
Yeah, from a medical point of view is if you're worried about it, tell the nurse. Is the first thing, because as Eleanor said, if you're worried something's going to be painful, if you've had maybe penetration or a previous painful smear, you know, which might have been 5 years ago, and a lot of women stop having sex in the menopause and might not have had anything in the vagina since that smear. I would talk to the nurse or even talk to a GP about it first, and consider having a blast of a vaginal estrogen before you go, because it'll just help that really delicate tissue. It might just give some elasticity back and just help it be a little more comfortable. You can ask the nurse to use a smaller speculum. The speculum is the thing that goes in the vagina to open up to see the neck of the womb. And it's also worth getting somebody to do it who does loads of smear, you know, somebody who's really experienced. For example, I'll sometimes do difficult smears because I've done a lot of gynecology, and it's just having somebody who's gentle and confident, I think. Eleanor, would you add to that?
Yeah, I think I'd echo exactly what you said. It is worth knowing that it is okay to use a lubricant when you're having your smear. So you can use the estrogen ahead of your smear, use a vaginal moisturizer ahead of your smear. Be really, really disciplined with making sure you've used plenty of moisturizer and estrogen up to the point of your smear. But placing lubricant around the edge of the speculum is absolutely fine. It's not going to interfere with the results in any way, and you can take your own lubricant with you if you want to do that. And I think actually practicing, so using dilators to get to the point of a comfortable smear is absolutely fine. Going through some, you know, if you were using your dilators in preparation, go through some relaxation techniques. So take some music, put some headphones in, you know, close your eyes, imagine you're somewhere else on your beach. And actually it's okay to ask for a longer appointment, to take your music, to lie down, to not have to engage in a conversation about what you're doing later in the day. So I think it's okay to be prepared in that way.
And I should have said, I mean, if I use a vaginal estrogen before a smear, you want at least 6 weeks, 6 to 8 weeks of using a vaginal estrogen. It won't work overnight. So again, be prepared, you know, think about it in advance, book an appointment to discuss it if you're worried.
Claire, that's brilliant. And I think for some of the questions coming in, we will write this up and put it in a post. And some of you have questions around, are we recording? Yes, we're recording this, and we'll share it in a couple of days. And we'll send it out in an email, and we'll reference the product recommendations as well, the brand recommendations, and put in some of the links to Eleanor's website, Sue's, and our own as well, so that you have all of the information in one place. So Sue, the importance of therapy and talking really came through in what both Eleanor and Claire were saying. So what would your advice, and in your experience, what do you recommend to people who come to you to help them think about how they manage painful sex or vaginismus? How do you help them to think about relaxing? I'm sure easier said than done.
Yeah. Yes, it is, because obviously all of the above things are very important. You know, we have a physical pain that's has an identifiable cause, a biomedical intervention with a vaginal estrogen or systemic HRT, or both, is of course on the cards. Equally great pelvic floor awareness, and as Eleanor said, not just the ability, I think we're often told, aren't we, oh, you've got to squeeze your pelvic floor until, you know, imagine you've got a £10 note between the cheeks of your bum and somebody's trying to steal it. And quite often you've got to turn that upside down and say, well, hang on a minute, I'm actually too tight and I need to learn to relax. So absolutely what Eleanor said. And that's all part of what comes into psychosexual therapy. But we also have to think about the other two very important parts of our sex lives, which is the psychology, as you mentioned, and the kind of sociology, the relational stuff that goes alongside. So often with the psychological impact, there becomes this inability to relax, a fear that pain is going to happen again. That leads to a reluctance to participate in intercourse, and can lead on to a loss of desire. And of course, that in itself can then make the problem bigger, because the partner now feels blamed or feels a sense of rejection. There might be a complete withdrawal of general intimacy because, oh, if I'm a bit intimate, well, it might lead to sex, and I definitely don't want that because it hurts. And so you end up in this downward spiral of awfulness that really doesn't need to happen. So in psychosexual therapy, we try and look at these three components and how they're impacting on the woman that's presenting, but also on the partner, and really try to understand the interplay that's going on in this room and in this relationship, and try and kind of engender, I call it the 4 C's. Everything comes in numbers in my world. You'll see later on. The 4 C's: connectedness in the relationship, compassion, great communication, and some curiosity about how things can be different in the future. And often that can start with a complete kind of ban on having intercourse. We're going to not have sex for the next X number of weeks. And we're going to build up this feeling of other sexual pleasures, often starting with touch. People think, oh, you're just going to have a massage. It's not that kind of thing. It's much more guided. And in therapy, we're not kind of counselors. We're not people that just sit and listen to the problem. We guide, and we're very instructive in therapy. So people go away with a set of experiments or exercises to do at home, and they come back and tell us how they went, and they build up to creating a much more comfortable sex life, which may or may not include intercourse. It depends what the couple want to achieve, but also incorporates all those other things that Claire and Eleanor mentioned.
And Sue, do you always recommend that couples come in together to see you?
If there is a couple, if they are in a couple, it would be great if they came together. I do see people as individuals occasionally, but I do think that this kind of problem belongs to this relationship, and both partners are most welcome and really encouraged to come.
That's really good to hear. And Sue, we had a great chat a few days ago, and just before the call this evening, around why sex is so important. Again, given your extensive experience in this area and what you see of life, why do you think it's so important to us? Why is it so important, period? Why is it so important in a relationship?
Yeah, well, let me put it. I'm going to come at this with my healthcare hat on, I suppose, because I'm very evidence-based in the way that I approach things, and I do love a good research study. And there's loads of evidence, and one in particular, one study looked at, do women care about sex? Now, I care about women, and if women care about sex, then I'm bloody in there getting this sorted out. And this study included 14,000 women from 29 different countries, and 76% of women felt that satisfactory sex was essential to maintain a sexual relationship. But even more interestingly, there was a direct correlation between sexual well-being and overall health and longevity. And so it's not just about the quality of your life, but it's about the quantity of your life. And why wouldn't we be interested in that? Sexually active women have a better quality of life and live longer. And like I said, sexual activity doesn't have to involve intercourse. There are lots and lots of ways to enjoy your body and your partner's body. But it's really nice to have the option to have intercourse too. And like you said earlier, we don't live in a world of Outlander or Sex in the City where we're constantly at it. Sex drive changes. We're not as lustful as we normally, as we were when we first met. It's kind of natural. And sometimes we have to learn to manage that in a different way, to find another kind of motivation for lovemaking in the absence of really rampant desire for each other. And that's with or without the menopause. I often work with people who have spinal cord injury and feel very little, vaginally or in their pelvic girdle. but they still manage to have a really great sex life. So yeah, it's very complex, isn't it?
Mm-hmm.
So it is, Sue, but that was a really beautiful explanation, I suppose, and a description why this topic is so important. And the question I'm about to read out is a great segue into, I think, kind of the next topic. And thank you very much for asking this question. Are we going to cover a lack of interest in sex generally and finding it harder to get aroused and reaching orgasm? So probably a great point to talk about desire, arousal, and things we can do to make sex even more fulfilling. We'll open it back up to Claire and Eleanor as well. So jump in, Claire and Eleanor, as well, after Sue's kind of set this up and discuss this.
Sorry, can you just rephrase the question? Can you just get me?
Yeah, sure. No, of course. So there's we discussed the point around desire and arousal. So how do you reignite the interest in sex? So what are the things that you can do to fan the flame, I suppose, again? And the difference, I suppose it's very helpful to explain then in that the difference between desire and arousal. And Claire, we'll come to you then to talk as well about what can be done medically. And I think we'll tie in some of the questions we have around testosterone to that too.
Okay, so I'll come to another study to answer that question. And this was a study by the University of Texas. And they asked 400 people why they have sex. And out of those 400 people, I don't know, I could ask you to guess, but I'll tell you the answer. 237 different answers were given for why people have sex. So really, when it comes to answering the question, I suppose only the individuals that are in front of me can tell me why it's important to them. Without lashings of lust, however, women do find motivation for sexual interaction. And some find that because it expresses physical tenderness or emotional connectedness or confirmation of desirability. And it's often related to the quality of the sexual life before whatever has changed, whether that's a life-changing illness or whether that's a spinal cord injury or whether that's the menopause. So when it comes to talking about desire and libido, I suppose in general, people often say, oh, I've got no libido, it's up and gone, or my pilot light's gone out. Sometimes it's a question about, do you desire? Do you want to have sex? Do you want to be connected in that way? And if you do, what would motivate you to participate? Now, of course, we're not going to be encouraging anybody to be having sex that really doesn't want to have sex, or most certainly not in an abusive or coercive relationship. But for the people that would and who really mourn the loss of their libido, sometimes it's about kind of reframing the situation, because we know that for people who have no drive as such in the way that they would have described it before, sometimes by participating, by actually starting to make love, to touch, to be tender, and to really be compassionate and connected with your partner, you find that actually you are really quite interested, and there is a response, and you really do have very nice lovemaking, often with an orgasm. And by doing that, by having that experience, it makes you more likely to repeat the process. And I know lots of people will say things like, oh, well, you know, if you don't have sex for a long time, you actually want it less. And that is probably true. So sometimes there's a lady who did a really great diagram. So it's called Basson's model. And it shows that actually lovemaking, particularly for women, doesn't have to start with desire, but desire can come afterwards as a response.
Yeah, Sue, you've put that so beautifully. Thank you so much. I think that's what I try and get over, but don't in any way as eloquently as you do. It's funny, isn't it? It's the difference. It's splitting it up. It's the desire that really commonly flies out of the window, particularly in the menopause, where you've got so many physical symptoms a lot of the time. So feeling hot, you might have put weight on. You've got the psychological symptoms of anxiety. You might feel flatter, low mood. Heaven only knows what's going on at home, at work, trying to keep all those balls juggling. And so then when it comes to desire to have sex, there are lots of factors that may be conspiring against you. But it's understanding, isn't it, that a lot of the time the physical arousal can be maintained. There are receptors waiting to be fired. And as you say, if you take the pressure off a little bit and you do just work with your partner, actually that positive feedback can just be so helpful. I think you put that so well. Thank you. I mean, a lot of the time, you know, I am hearing in the clinic, and I wonder if you guys are too, about people sort of getting frustrated that it takes longer to come to orgasm, for example. And one of the issues can be those physical changes that I talked about earlier in the loss of estrogen. So the loss of blood vessels, that I would say medically, loss of vascularity. So the blood supply to the area is not quite as rich as it used to be. And you may be therefore needing to adapt, maybe needing to use a little extra stimulation than you usually would using a vaginal estrogen. But how anxiety can then make all of that worse, and then getting into a vicious cycle. I mean, I think I see that in my clinic. Would you say you saw that from your point of view as well?
I would certainly, yes. And there's a kind of an added level to that as well, because maybe people are aware of the amount of stress that they're under, and maybe actually, you know, they would rather be sorting out little Johnny's football kit or something, you know, just to get that one extra burden off. But there's also this kind of thing going on in your head about it's all just too stressful, and now I'm listening to my body. I'm listening to my body because I'm expecting it not to happen. You know, I'm worried that it's not going to happen. This is an additional stress. And, I'm being asked, amongst this huge list of things that I've got to achieve, to do sex. You know, it's another chore. And sometimes it's very easy to get really fixed into that, and it stops you being able to enter fantasy, or maybe to seek other options for stimulation. You know, nowadays we live in a time when, God, there are things that are available to us in our sex lives that have never been available to previous generations of women quite so easily. And, you know, you can find all kinds of porn, all kinds of toys, all kinds of lubes. You know, be curious and try and not listen to this negative, my body has changed for the worse, because actually sometimes people find that the menopause is actually quite liberating sexually if they can just kind of change their own script a bit.
So this conversation has thrown up a series of questions, which I'm going to put out to you guys, starting off with, and Claire, I might put it to you. It's a question around, you know, biologically what's going on. So there's a series of questions around changes experienced to the intensity of orgasm or completely changed. That's one. So is menopause a cause of that, I suppose? And then follow on for you, Claire and Eleanor, and maybe back to you then, Sue, about, so what can I do about it? So Sue, you mentioned, we've touched on lubes already. We haven't so much talked about sex toys and other things we can do to kind of stimulate the desire and orgasm as well. But I think it would be really great if we could get into some, you know, really practical advice that we can give people who are listening in tonight. So Claire, maybe starting with the first question around, is a change in sensation around orgasm, finding it harder to orgasm, is that often, do you see that often with women going through menopause?
Yes, particularly if you ask about it. I think women are still quite embarrassed about talking about it. And so sometimes I will ask about it when I'm talking about libido. And that can be a cause of, as we've said, of anxiety, of pressure to perform, etc. And that can be absolutely related to loss of estrogen. And for some women, it can also be related to loss of testosterone as well. So just in terms, really briefly, our estrogen level falls off a cliff in the menopause, and the testosterone level slowly trickles down, probably from the 30s. And for some women, that doesn't seem to make very much difference at all. But for some women, it does make a big difference. I prescribe a lot of testosterone for libido, and I wish it could come with a bit of Sue and a bit of Eleanor with the prescription, because I prescribe testosterone, and there is evidence that it can increase sexual function, it can increase arousal marginally. The studies on testosterone were mainly done on women with a condition called hyposexual dysphoric disorder, where there was zero sexual thoughts, zero sexual function, and it increased the sexual thoughts by about 1 a month. Now, my patients tell me that they are getting benefit from it a lot of the time, and that's brilliant, but a lot of people don't, and then feel really despondent. And that's really sad that the treatment is causing you to feel worse. But I think it's because of what Sue and Eleanor have touched on. It's not just that physical bullet that you need. It's not just the testosterone. Yes, by all means, try it. The risks are really low, but you probably need a dose of thinking and imagination and communication and all of that as well. Yeah.
Claire, before we come on to Eleanor and Sue, just a very practical question that's come in here, which we often get asked again, is why is testosterone only available off license, and why is it not available on the NHS?
So testosterone is available on the NHS. So there are really super briefly 2 types of testosterone that are prescribed. Androfem is 1% testosterone cream. It's imported from Australia and it's only available privately, and it's quite expensive. Our pharmacy, it's £80 for 100 gram, sorry, £80 for a 50 gram tube that will last about 100 days. You, on the NHS or privately, you can prescribe Testagel or Testim, which is still 1% testosterone, but it's a gel rather than a cream. It comes in little sachets, and you have to, it's a bit of a faff, basically. You cut the corner off the sachet, you squeeze a tiny pea-sized amount out, petit pois, not garden pea, definitely not marrow fat pea, and then you rub it into your thigh every day. There is a 2% Tostrin gel as well in a pump. I tend not to prescribe that just because when I'm checking levels, they're often higher with Tostrin. But it is available. It's not licensed, and who knows if it ever will be. And that's probably commercial demand and the pharmaceutical industry issues. But who knows whether that will change with, I mean, I am prescribing a lot of testosterone, and I can, fingers crossed at some stage in the future that will change. Does that answer the question?
It does, I think, Claire. I'm guessing, though, what's behind it is that a lot of women are not getting it prescribed by their GP. So it can feel like it's not prescribed on the NHS.
Yeah, so that's another matter. So a lot of I am a GP as well, and a lot of GPs wouldn't feel comfortable prescribing testosterone. GPs generally don't want to do harm. And if you're not comfortable prescribing off licensed medication where there is additional prescribing risk, or you may not have the experience, I would say the majority of GPs wouldn't feel comfortable prescribing it. So asking for a referral to somebody who will prescribe it, you might have to wait a bit, but that would be the other way forward.
Yeah, so specialist NHS menopause clinics like the one that you also run in Leeds, Claire. Yeah. Okay, super. So lots of questions now coming in about arousal and top tips for arousal and for reaching orgasms. Eleanor, if we kick off with you, and I don't know if you've any more of your gadgets or anything that you can show us.
I've always got a few.
I know, always interesting. And Emma, I'm just helping in the chat. I wonder if you might be useful to put in a link to Eleanor's website into the chat as well, and people can see the full range there too.
So something Sue touched on earlier, but I really would recommend exploring what is out there for women in terms of literature, reading. There are some really good sexy podcasts that you can listen to. And I think, especially if it's taking you a long time to get aroused, or you're just feeling like that desire isn't there, reading and listening and exploring porn if it's something you want to do. There are some really female friendly so there's a porn site called Frolic Me, which is a female owned business, and it's fantasies that women want to see. You know, so there are some safe areas to explore this sort of thing, which is always worth thinking about. I have got a couple of little devices with me. So I bought here, this is called Gwen, but it's a really lovely soft silicone clitoral vibrator. And I always think a clitoral vibrator, if you've never explored sex toys at all, is a really nice place to start, because especially if you are maybe not finding penetration comfortable, or you don't want to go there yet, it's a really lovely starting point. So that's a little clitoral vibrator, and you can use it on your own, or you can use it with your partner, between yourself and a partner. So that's a lovely sort of starting point. There are also some really small vibrators out on the market. That there's one called the Slinky Pinky that I know a lot of GPs and physios recommend. But again, it's about the size of your little finger. You can even get them on Amazon, and it's a really nice starting vibrator if sex has become painful, because it's so small. I often we do hold the Gwen clitoral vibrator and another sort of flexible vibrator, because it's nice sometimes to be able to go somewhere that isn't a sex toy shop if you've not bought a vibrator before. So it's a really important part of what I can offer. But there are some other lovely sex toy websites. I recommend often Joe Divine. Joe Divine is owned by a nurse. She was a nurse previously, and they've got a really good advice section for people who have got different gynaecological concerns. And Samantha Evans has got, writes a lovely blog, and there are some safe entry points if you're feeling quite overwhelmed with what's out there. So I think you can dip your toe in the water without having to dive headfirst into something that you've never tried before. And then SH is another one I recommend, SH. And they've got some really lovely introductory vibrators, advice for if you're suffering with different gynecological concerns, so advice around menopause. So I think it's just about being signposted to the right place sometimes, and not being afraid to try something, and being okay to try something and think this isn't for me, and step back from it. You're not, you know, you can try and it can be not the right thing, and that's absolutely fine. I think that's important to remember.
Brilliant. That was great. So I'm just going to hand over to Sue then, but Eleanor, while Sue's speaking, would you mind, we have lots of questions around the name of the Sexy podcast or website, if you wouldn't mind putting into the chat the names of the websites that you've just mentioned, that would be really helpful. So Sue, over to you now. What are your thoughts for, you know, creating that mood and that environment?
Yeah. All the things that Eleanor said were absolutely brilliant. Thank you, Eleanor. That was really great. But also, I think if you're in a relationship, try and bring your partner with you on this adventure, and really try and view it as an adventure. You know, really, your partner should be. Well, I don't like to use the should word, but wouldn't it be wonderful if your partner was your best ally? Try and explain what's going on for you. If you don't want to have vaginal intercourse right now, then say so, and you know, explore, but don't make it like, but that's it. You know, there are loads of other things, loads of other pleasures that can be had for both of you, and try and help your partner to understand what's going on. Explain that you understand that it affects them too, and that you are concerned about them. And like I said, recruit them as an ally, and be curious about what you can do about the situation, because it may well change again. You know, this may not be forever, it may just be for now. And give some hope, you know, and really believe it yourselves that there is a hope that your sex life is going to be better pretty soon. However, if you just stop, don't discuss it, and don't do anything about it, it will not improve. You know, you really need to take action. And if you need some questions, we talked about how do you start that conversation if you've never had that conversation before. And there are lots of people that come to sex therapy that are in that situation. They've always had sex in a very kind of, we know what to expect from each other kind of a way. And when something suddenly changes, they're not practiced at speaking to each other about lovemaking. And it can be a really tricky thing to begin. So I think it was only a week or two ago, I wrote an article on my website about beginning those conversations, how to start. And not just how to start with your partner, but how to start with your healthcare provider as well. How do you get those first words out of your mouth when it's gone dry, your heart's beating out of your chest and you feel ghastly? And it's almost like the reverse of the boy going in to buy condoms and he comes out with everything in the shop except for the condoms. You go to the doctor wanting to speak about your sexual problem, whatever that might be, and you come out with all kinds of other things. So I think it's a really important, like I said, women are important. You are important to me. Please do something about it if you're not comfortable and you're not happy.
Brilliant, Sue. And Sue, what would be fabulous is if you have a moment, if you could pop a link to your blog into the chat as well. And we, as I mentioned, we'll post it out as well and put it in the email, because from everything you said, I think it'll be invaluable for people to read it, because it's one of the hardest things, isn't it? Sometimes you're with a partner for such a long time, things can become formulaic. It's almost embarrassing to start over again, to have those conversations, and it's definitely coming through as a theme. I'm conscious we're into the last few minutes. I think there are some questions that we haven't quite answered. So if everybody's okay, this might feel a little bit like mastermind. I'm just going to throw out some of the questions that have come through. There are a few around HRT specifically, so I'll hold on those, Claire, to group them together for you. So I'm just kind of going to the top of the chat. I think there are two questions which are similar, and I'm just looking for it here. One was, if I suffer from vaginal dryness, can you cause damage to your vulva or vagina if you have sex when you have severe dryness?
From a medical point of view, yes, sadly, lots of women get little tiny tears or even bigger tears, and it's incredibly painful. And because the tissue is so sensitive and delicate, they can then take ages to heal. So if you've got vaginal dryness, it's really important that you reduce the friction to try and prevent tears. With, as Eleanor said, I often tell women now to use double layers of lubricants. The oil-based lubricants are really helpful. So you can, and you just have to judge it so you don't have a little tear, which can be agony.
I'd really recommend using that oil-based lubricant and the water-based lubricant in conjunction, because you get that water slipping over the oil, which really reduces any risk of friction. The other thing that is lovely is that oil-based lubricant can be used like an emollient day to day. So if you're getting chafing, if you've found that you've got a little bit of stress incontinence because you've got a slightly weaker pelvic floor because of all the reasons sort of we've discussed, that can cause a little bit of irritation. So a little bit of oil-based lubricant, or if you're using a pad and that's causing irritation. So I always recommend organic pads to try and get rid of that bleach. So we don't want anything that's going to cause irritation to the vulva. And some oil-based lubricant just as a day-to-day emollient to protect that tissue from the chafing, really sort of get ahead of the problem rather than trying to sort of sort it out afterwards is always helpful, I would say. Brilliant.
That really great, really practical advice. Sue, a question for you. Any recommended training for psychosexual therapy? The question has come in from the questioner saying her waiting list is a year and she wouldn't mind getting some training to help patients with vaginismus.
With vaginismus, okay. I only know of the big organizations that would qualify you to be a psychosexual therapist, and all of those that are kind of approved, if you like, are on the College of Relationship and Sexual Therapy website. So if you wanted to find a place to train to be a sex therapist, it's usually a 2-year, well, my training was a 2-year course. It's long and it's generally quite expensive. I don't know, Eleanor, if there are particular kind of short courses for vaginismus.
I know that, and actually, Claire, you may, but the Royal College of Obs and Gynae always do. For GP, are we talking about for GPs? Sorry, Helen, or?
It just came in as a general. I don't have the context, Eleanor, so.
Okay. Yeah, so for healthcare professionals who just want to specialise a little bit in this area, the Royal College of Obs and Gynae do some good courses. I think the British Menopause Society. I assume that's where the sort of questions come from.
Okay, the other option, of course, for people that are waiting for a referral to psychosexual therapy, another option is to explore your local Relate office for people that are in the UK. Most Relate centres have a psychosexual therapist as part of their team, and it may be that you can get an appointment there far faster than you would get one within the NHS.
Yeah, and that's a great segue into the next question. So can you get sexual therapy on the NHS?
Depends where you are in the country. Unfortunately, it comes down to commissioning. Some places do have a large psychosexual therapy service, others have none at all. But it is always worth exploring whether the next area to yours has a service. If yours doesn't, is that something that you can access? Really try and be curious and seek a solution, but certainly find out about your local Relate. And there's also on the College of Sex and Relationship Therapists website, I'll give you the link. There's a Find a Therapist service as well. You can just put in your postcode and it'll tell you the therapists that are nearby to you, most of which may be private, but some may also be NHS.
Super. Thank you, Sue. Big Fab, if you could stick that in the chat as well, and we'll include that. And Penelope, thank you for clarifying. So yes, Penelope's just clarified that the training is for GPs. So thank you for that, guys. So a few HRT related questions. Dr. Clare, a question here from Susan saying her doctor is very hesitant to give her HRT because of blood clots. It's taken her 12 months to get a clotting test, and the next appointment is the middle of April.
Yeah, so traditionally, if you'd had a blood clot in the past, people would be very anxious about giving HRT because most of the HRT was given orally, and if you swallow estrogen, it probably doubles, if not more, the risk of having another blood clot or stroke. So people don't want to cause harm, but if you have estrogen through your skin, we don't think it increases your risk any further. So you'll have your raised baseline risk because you've already had a blood clot. And if you have transdermal HRT, so the estrogen as patch, gel spray, it probably doesn't increase that baseline risk further. So unless you've got a very complicated clotting history, most people now would be able to have a transdermal form of HRT. Again, your GP might not feel completely comfortable prescribing it, and if they're not, then you can be referred to a specialist clinic, or some of the gynaecologists, depending on where you live, will have an interest in the menopause.
Super, thank you, Claire. Claire, I'm not sure if you got it in the chat, but I popped you over. It was a longer question from a lady who's had a DCIS, which was treated with surgery and radiotherapy. She's low sex drive, aching joints and pain in sex, amongst other symptoms. She's a Mirena coil in place, going through menopause, and her consultant says she can't have estrogen.
So it's worth having a discussion, or asking your consultant to have a discussion with a breast surgeon, because not all breast cancer is equal, and some will have a more risk of recurrence or be than others. But it's becoming more and more common that women who have a history of particularly DCIS would be able to have a vaginal estrogen, because the amount you absorb into your body is absolutely minimal. And then the discussion about systemic HRT and DCIS, it really depends on your exact diagnosis. And I would often discuss with a breast surgeon or an oncologist about the risk of recurrence of that particular breast cancer before then having a discussion about HRT. I'm usually really happy to prescribe HRT, but I think from your point of view, you need to understand the risk of recurrence, and then just the uncertainty about safety of HRT when you've had a diagnosis of breast cancer. DCIS is a bit less risky. DCIS is sort of more pre-cancer cancer, but it's worth a discussion with a specialist to specialist, so you understand the risks and you can make an informed decision.
Brilliant. So second last question, quickie for you, Claire, again. Can you have testosterone if you've had ER plus breast cancer?
Can you have testosterone
if you've had ER plus breast cancer?
Yeah. You probably can. As far as we know, there's no increased risk of breast cancer or heart disease for that matter from using testosterone. The data is pretty short term, so the best quality data is probably just 2 years. We know that for 2 years it shouldn't increase your risk. There's observational data that lasts a bit longer. Again, it completely varies in circumstances. The NICE guideline advise that you should only give testosterone if you've already got estrogen on board. It's a careful discussion with a specialist, I would say, about whether you have testosterone by itself, because some testosterone will be converted to estrogen. Slightly controversial whether that increases the risk of recurrence of breast cancer or not, but you would need a discussion with a specialist, I would say. Potentially yes, but careful discussion.
Thank you. And Christine, thank you for waiting. Last question is from you then. So she says her pain begins halfway inside the vagina, not the cervix, during sex. GPs done swabs, all are normal. What can she do? She's had breast cancer 8 years ago, so can't have, or has been told she can't have HRT.
So I'll answer it first, and then maybe others can chip in. So breast cancer 8 years ago, you probably, unless you're taking an aromatase inhibitor still, which is probably unlikely, it probably would be fine to have a vaginal estrogen. So that would be a starting place. And then Eleanor and Sue would probably have helpful things to say about alternatives to vaginal estrogens also.
Yeah, I mean, I'd really recommend trying the Yes range, trying the moisturizer on a daily basis, and then the lubricants as and when you need. And it is worth thinking about the O-nut, which I mentioned earlier, the silicone rings, because if you're getting pain on deep penetration, that's just going to stop penetration from reaching a point that's painful. So from a devices point of view, those would be the two things that sprung to mind initially when that question was asked.
Brilliant.
Similarly.
So that concludes it, guys. We've run slightly over, but that was, just like I say, a huge thank you to everybody for joining, but particularly huge thank you to Sue, to Eleanor, and to Dr. Clare. You're amazing women. And it is, I think one of the most moving messages that we've seen this evening is where somebody's put into the chat that this has given them hope. And, you said at the beginning, we know that women are living longer. We know that you have the evidence now from that study of 14,000 people that when you have a good and healthy sex life, it prolongs, gives you a better quality of life as well, and a better quality of health. That's why it's so important that we normalize these conversations. And it's just very matter of fact, there are solutions there. You heard from our 3 wonderful women, experts in their areas. There are things that you can do, probably not a silver bullet on its own, it's the combination. So we'll be posting the video. We've got lots of great content from Sue coming in, the blog that we linked to, on Eleanor's website and on our own, and we'll be signposting to that over the coming days as well. So thank you all very much, and a big thank you to Emma as well, who's been helping us stay on track in the chat as well, and posting all of that useful information. So good night, everyone. God bless, and thank you very much. Bye-bye.